So hysteroscopy is and should be the gold standard for diagnosing intrauterine cavity pathology. And I think it's important that we really understand that. And in order to understand that, you need to understand what's available to do a hysteroscopy. Obviously, with any procedure, you need to know the complications and how to manage those complications. And then once you're doing the hysteroscopy, it's essential to know what it is you're looking at, what's normal. You have to know what's normal so you know what's not normal. So I'm just going to give a brief overview for the residents and everyone, just so different available instrumentation. Currently, there's flexible hysteroscopes that are often used in the office. Um, Speaking of which, office hysteroscopy over the past, I don't know, I'd say 2 to 5 years maybe has really become more commonplace. I know there's a big push in private practice.
Dr. Lieberman. Seem to be having some technical difficulty. Let me give him a call. Dr. Lieberman, if you're talking, we don't hear you yet. You are unmuted. No, we cannot hear you. Maybe you have to reconnect your microphone because we see you're not muted. If you go to the mute button at the bottom left of the WebEx screen, there's a little triangle, and if you click on that little triangle, you can select a different microphone. And it's not a matter of being muted, because I can see you're not muted and that you're using some sort of headset. Right. So can you see the WebEx controls right now? If you go to the bottom of the screen, do you have one screen or two? Do you have one or two? So just stop sharing for a minute. If you go to the top of the screen, there's an orange menu and you can hit stop sharing. And now you're not sharing. So now if you go to the bottom of the screen where it says mute or unmute, and there's a little triangle, if you click on that triangle, it will give you some options to connect or not connect your microphone. Do you see any menu options? Like where do you see share? Okay.
Can you hear me now?
Yes.
Okay, so you could hear me now.
Yes.
It's like a Verizon commercial. All right, hold on. Can you see my PowerPoint?
Not yet.
Hold on.
It might be coming though. It might take a second.
Can you hear me can you hear me? All right, so we should be good. All right, if there's a problem, just call me back. Thanks. Sorry about that. Some technical difficulties, I guess. So yeah, just briefly then we'll just go through some stuff. I was just basically going over the different instrumentation that's available for hysteroscopy. There's flexible hysteroscopes, rigid, and operative. In the office setting, people are using the Endo-C or other instruments. Those do not have an operative channel, so basically you're just able to look. It kind of replaces the saline infusion sonohystogram. When I do office hysteroscopy, I like to use a 4.9 millimeter diagnostic scope like you see in the upper right-hand corner, where there's an operative channel so you can actually perform polypectomies and anything else you need to do, such as remove IUDs. For the operative hysteroscopes, there's energy and mechanical. I prefer the bipolar energy. In terms of mechanical, I know there's been a big push over the past few years to use the mechanical. Probably for the last 10 to 15 years, industry has really, gotten into the operating rooms and have really pushed for the TrueClear and MyoSure. When I did my fellowship, when I trained, I learned a lot of bipolar resectoscope. In my opinion, these mechanical morcellators have some advantages you'll hear about. There may be shorter operative time. It allows certain gynecologists and, to do hysteroscopies or operative hysteroscopies that may not otherwise be able to, because it's a little bit easier to use. In terms of disadvantages, all these instruments, the mechanical ones, are disposable. They're expensive. Each time you use one, it's about $500 to $700, depending upon which one you are using. Also, there is no ability to coagulate or cauterize any bleeding, which increases, obviously, risk to patient and intravasation of fluid. These are just some pictures. The one on the this one here, the top left one, is a mechanical morcellator. The bottom right one, which is the one that I prefer, it's a bipolar hysteroscopic resectoscope. It's 7 millimeters. And above it, you see these instruments. There's different instruments available, whether it's a hook or a roller ball that allows you to, depending upon what you're doing, whether you're resecting fibroids or doing an ablation or doing a uterine septum. Office hysteroscopy. So, there's been a big push for this, which I think is great in the past, 5 years or so. The advantages of office hysteroscopy: higher patient satisfaction has been reported, faster recovery, it's convenient for the patients. The patients don't have to deal with going to a surgery center. Also, it allows for more efficient use of operating room time in the main ORs, and it frees up the availability for the ORs for doing more complex cases, not only hysteroscopic cases, but just cases in general. In terms of getting ready to do a hysteroscopy, there's different times and different ways to prepare for it because you want optimal visualization. The optimal time to do the hysteroscope would be in the follicular phase of the cycle. Usually this is days 5 to 9. Obviously, you want to exclude pregnancy prior to doing a hysteroscopy. And if you have a patient, oftentimes patients with abnormal uterine bleeding have irregular cycles, and therefore you won't be able to plan when you're doing the hysteroscopy to be within days 5 to 9. In those cases, I usually give medroxyprogesterone 10 milligrams for 10 days, let them have a withdrawal bleed, and then do it, usually days 5 after the withdrawal bleed. Just for the residents, there's different types for cervical dilation, obviously. If you're doing an office-scope, oftentimes it's not necessary to do dilation depending upon the patient. Obviously, if you have a patient with 3 prior C-sections and cervical stenosis, she's not going to be a good candidate for an office hysteroscopy. But when you're in the OR doing it, there's different types of dilators to use, and it's important to know the different ones. I personally prefer the Hagers. The other ones are, I've been associated more with perforation. A way to remember: the Hanks on the bottom are like shanks, Hank for shank. They could be sharp at the end. The Hagers are shaped like cigars. And then there's the Pratts. So when you're encountering, when you're planning to do your hysteroscopy, whether it's in the office or whether it's in the main OR, and you're concerned about cervical stenosis, some ways to get over that or to, get in when you need to, you could give misoprostol. It's been recommended 400 mcgs vaginally the night prior to the procedure. Also, sometimes it's necessary in extreme cases with cervical stenosis. You may not even see the external os. In those cases, you can even do a minor leap in order to remove the excess, the external scar tissue, and open up the os, or an 11 blade. Oftentimes, I'll try to just dilate the external os only, and then put the diagnostic scope in, and then use the graspers you see in the bottom right to push in an open and spread technique, and then go in under direct visualization. And that's especially important when you're, first starting the case and you're going to do dilating and you hit a rock, you feel it's hard and you don't feel the canal. It's important to stop, because that's when you're going to cause a perforation if you push through that. And it's good to put the diagnostic or the scope in the external os and go in under direct visualization. There's different distending media. Obviously, most nowadays we use normal saline. It's important to know about, oftentimes, the mean arterial pressure. You can ask the anesthesiologist what that is. You want to try to keep the intrauterine pressure below the mean arterial pressure to decrease the amount of extravasation of fluid into the patient's circulatory system. This is just a nice schematic of the different pressures. And as we know, the uterus is a muscle, so there is different levels of pressure required in order to open up depending upon where in the uterus you are. So that's where, usually we use 100 or less than 100 milligrams of mercury. Just briefly to go over different types of distension media, just to know about these. Oftentimes they'll ask you about these on, pre-augs or written boards. Nowadays, I have never seen carbon dioxide gas, but, back, I don't know, a few decades ago, they were using this. Obviously, there's a risk of gas embolization with this. When people use monopolar energy for resectoscopes, it's important you have to actually use glycine or a electrolyte poor solution. The problem with this is that it can very easily lead to hyponatremia, and it's obviously not good. The electrolyte containing solutions such as normal saline, this is what I use and what most use with bipolar resectoscopes, or when you're using the TrueClear, the MyoSure. The reason it's readily available, it's isotonic. You can still obviously have problems such as pulmonary edema, CHF. It decreases the risk of hyponatremia compared to the electrolyte poor solutions, and you cannot use this with monopolar energy. Just to go over, this is just showing you that it's not necessary to give antibiotic prophylaxis prior to hysteroscopy. Another thing to consider is nerve injuries. Does anyone know what the most common type of nerve injury is in GYN surgery? It's the femoral nerve. This is just a schematic just showing the femoral nerve distribution. It's important to always consider positioning in patients, especially doing any minimally invasive procedure or any procedure in general. I don't use candy canes anymore. This is an old schematic of candy cane stirrups. I've gotten away from using those because of increased risk of nerve injuries. But the top picture, one of the reasons femoral nerves injury is the most common is when you're doing hysteroscopy or other procedures, the femoral nerve can get entrapped under the inguinal ligament with hyperflexion of the thigh, as you can see in the top. So in terms of positioning is very important. You don't want to have too much overhang because then the patient will wake up with back pain, but if you don't have enough, it makes it more technically difficult. Don't flex the thigh greater than 90 degrees and abduction no more than 45 degrees. And this is just going over, again, different nerves that could be affected and clinically how they could present. You want the patient to be flat on the table. Don't use Trendelenburg. Contraindications to hysteroscopy. Obviously, if there's a viable pregnancy, if they have any genital tract infections, you do not want to do a hysteroscopy. That includes herpetic lesions. You don't want to spread the infection. If they have known cervical cancer, you do not want to do a hysteroscopy either. So just to go over complications, because obviously you need to know about that for any procedure you're doing. So hemorrhage, uterine perforation, false passages can be created. This is when you're dilating and you meet resistance and you think you're actually dilating the cervical canal, the endocervical canal, but you actually create a false passage. You have to be careful of that. Cervical lacerations, fluid overload, visceral injuries if there's perforation, infection, which is very rare, air embolisms, which is rare but deadly, death, and then obviously delayed complications, which is important to counsel your patients on because they can develop intrauterine adhesions, which themselves can lead to infertility. This just breaks down. This is just a chart I made about the different complications to go over. Perforation is usually when you're blindly inserting instruments. I don't know, here where I am and other institutions, there's been a practice of sounding the uterus prior to inserting the hysteroscope. I don't understand that. Again, I like to enter the cavity under direct visualization. If you're sounding the uterus, if you perforate or if you're going in under direct visualization, there's no need for that, in my opinion. Air and gas embolism, this can be caused by repetitive instrumentation through the cervix. It's also important when you first start to do the hysteroscope or the hysteroscopy, you make sure all the air is purged out of the line. That means priming the hysteroscope and letting the fluid run through the hysteroscope, not in the patient, but outside the patient until all the air bubbles are out. Using excessive intrauterine pressure can also result in air and gas embolism. Fluid overload, you have to be careful of. Hemorrhage, and then vasovagal reaction. This is, especially in an office setting, you can have this when you enter the endocervical canal and doing any sort of dilation. So just to go over the more common ones a little more in detail. So perforation. So this is most common during operative hysteroscopies when you're either resecting a septum, myomectomy, or lysis of adhesions. It's very, very important that you do a good exam under anesthesia when the patient's asleep before you do any instrumentation, so you get a good idea, a mental picture of the location of the uterus. Is it anteverted, retroverted? It's just really important. Also the size. In difficult cases where you know that there's stenosis, you can have a ultrasound in the room at the same time and have, either your operating tech or somebody have an ultrasound probe on the abdomen so you could see yourself going in. Also, another tip is if you're doing some sort of operative scope, the diameters of those sheaths are usually larger, so you may want to start with a smaller diagnostic scope of 4.9 millimeters before, and go in with that first to find entry into the cavity, and then proceed dilating further, and then doing the operative scope. And it's important to know the thinnest part of the uterus is at the cornua, so that's most likely where perforations occur. Ways to avoid perforation. So when you do your exam and the patient's really anteverted, you want to raise up the patient on the bed so that you're able to really drop your wrist down and antevert the scope as you go in. And if they're retroverted, you do the opposite. You have them lower the bed so that you can lift your wrist up and go down with the camera head into the uterus. Some red flags of perforation: you may have loss of distension. You may notice a rapid increase of deficit. So in terms of management, because obviously it's important not only to recognize uterine perforation, but what to do next. If you have a fundal perforation that's created by blind instruments, whether when you sounded, you can manage this conservatively. Obviously, if the patient becomes unstable while on the operating room table, that's an issue, and you can't just manage that by observation. But mostly, if it's in the fundus, you shouldn't really have any major vascular issues. You could keep them in PACU for an extended period of time. Once you perforate, you should stop the procedure. If there's lateral perforations or posterior, you have to be concerned about, or if you were using electrosurgical instrumentation at the time of perforation, you should do a diagnostic laparoscopy. The reason for the lateral perforations, the uterine vessels are there. You can get hematoma formation, retroperitoneal hematoma formations. And posterior perforations, you have to worry about the rectum. Anterior perforations, you may want to put in a cystoscope. If you have any concern about a posterior perforation with the rectum and you're doing a laparoscope, you could always insufflate the rectum with a red rubber, occlude the colon distal to where the perforation, or distal to where the rectum, and put water into the pelvis for any air bubbles. Intraoperative hemorrhage, this would most likely occur during resection of fibroids. When you do the resection of fibroids, you often open up large venous channels, which allows more intravasation of fluid. So do you want to really avoid intraoperative hemorrhage? You can administer dilution of vasopressin into the cervical stroma. That's been studied and has been found to decrease hemorrhage. Like I was saying, using bipolar energy for resectoscope or operative hysteroscopes, you're able to cauterize the bleeding vessels as you go to decrease bleeding. With the mechanical morcellators, you do not have that ability. And then finally, if you're having a lot of bleeding after, you could tamponade, put a Foley catheter into the uterine cavity and insufflate that. You can maybe consider giving tranexamic acid intraoperatively. Obviously, if there's excessive bleeding, then you could proceed to a hysterectomy. If they're stable, you can consider a uterine artery embolization, but I don't know if you really have time for that. Just to go over fluid overload. So this is most common during hysteroscopic fibroid resections, like I was saying, because you open up the venous channels and you allow more extravasation of fluid into the circulatory system by using normal saline and or lactated ringers. But again, most use normal saline. You decrease the risk of hyponatremia compared to the hypoosmolar fluids, but you can still get pulmonary edema and CHF with fluid overload. And if you do have a large deficit in the PACU, you might want to obtain electrolytes to check their sodium. If you were using normal saline, you can consider diuretics. If you were using hypotonic agents, then you may want to, and your sodium level decreases. You have to usually replete it in the ICU because you worry about central pontine myelolysis if you replete it too quickly. So in terms of fluid overload and absolute stops, if you're using normal saline, 2,500 mLs is the absolute stop. I usually don't want to go that high. Obviously, it also depends on the patient's health. If she's a frail postmenopausal woman with CHF, you're not going to go to 2,500. But in terms of what you can go to in a healthy younger woman, or for your board purposes or pre-augs, 2,500 mLs is the absolute stop for normal saline distension, and obviously it's less for the other electrolyte port. And just to decrease the risk of fluid overload, again, the vasopressin not only decreasing the extravasation, it also causes contraction of the vessels and helps with the bleeding, so therefore decreases extravasation. In the beginning of the case, when you're doing your timeout, I tell them, the anesthesiologist, to please decrease the amount of fluids they're giving because the patient's going to be receiving fluid from deficit below. Carefully and frequently monitor deficits, avoid tunnel vision. That means don't just sit there and get so focused on the case and not worry about other things that are going on, such as the deficit and how long you've been doing the procedure. And as I mentioned earlier, consider lowered fluid deficit thresholds in elderly patients, those with comorbid conditions, cardiovascular, renal compromise. And in the outpatient setting, if you're doing this in your office, you don't want to go up your deficit to go up to 2,500. You should probably stop in the low hundreds. Cervical lacerations, always check at the end of the case. Make sure you don't have any when you take the tenaculum sites off. Silver nitrate, Moncel solution, or ferric subsulfate are both coagulating agents that are very helpful. And if need be, throw in a suture. It's better to deal with this while the patient's still asleep than in PACU and have to deal with vaginal bleeding. So for board purposes, triage purposes, and just in general, if all of a sudden you're doing the hysteroscopy and you have the anesthesiologist tells you have sudden hypotension or decrease in oxygenation, and I know on the boards they talk about you'll hear a mill wheel murmur. What is your thought? You have to think about an air embolism. So this is catastrophic. To help prevent it, as I said earlier, you want to flush or purge all the air from the tubing before you do the hysteroscope. Avoid Trendelenburg position. Make sure the procedures stop when you're changing the bags because you could introduce air into the system and into the patient. In terms of management, so you got to stop the procedure immediately. You place the patient in a left lateral decubitus position with the head tilted downwards by 5 degrees. You're not going to measure, but have the head tilted downward. Basically, this favors movement of air in the right ventricle towards the apex of the right ventricle, and the air may be aspirated by passing a catheter down the jugular vein into the right ventricle or performing cardiocentesis. I don't know how many anesthesiologists would feel comfortable doing this. Has a very high mortality rate. So it's really important to do everything you can to prevent this from happening. Obviously, it's rare, but catastrophic. So I just wanted to give you guys a brief overview. It's a lot of material on hysteroscopy, but I think it's important to understand, the basics, the setup, gaining entry, dilation, what you can do to prepare for if you're anticipating cervical stenosis, and then some of the complications that you may encounter during and how to manage some of those. So now when you're doing the hysteroscopy, one of my mentors once told me, the eyes cannot see what the mind does not know. Dr. Stevenson probably knows who I'm referring to. But this is true. So we're going to go over, and first you need to know the normal so you can understand or appreciate the abnormal. So this is a view of atrophic endometrium in a postmenopausal woman. This is normal appearing. Apologize if the picture's a little grainy, but basically you can see thin, uniform, homogeneous appearance of the endometrial lining. When you're doing your hysteroscope, it's very important, by the way, when you get in, to visualize the ostia, because that assures you're within the endometrial cavity. Also, you want to make sure you get a good view and inspect the entire surface of the endometrial lining. Using a 30-degree scope is usually helpful, or 12-degree scope, so that you can really appreciate the endometrial cavity in its entirety. So when you're doing
Please stand by. Hello? Yeah, we lost you again.
Do you hear me?
Yes, we do.
All right. See the PowerPoint?
It's coming. We see that it's coming.
All right, let me know when you see it. You don't see it still?
It's here.
Oh, you see it.
And we see the slide that says proliferative endometrium.
Endometrium. All right, good. All right, so let's bite. Getting back to where we were. So as I was saying, you need to appreciate, your eyes can't see what your mind doesn't know. So you got to appreciate the normal. So this is a normal atrophic lining in a postmenopausal woman. Secretory endometrium, if you don't do the preparation with the progesterone withdrawal, or you're not doing it days 5 to 9 of the cycle, you can encounter secretory endometrium. It's usually fluffy appearing. You may see gold specks. Proliferative endometrium also is fluffy appearing. Sometimes a little difficult to differentiate the secretory versus the proliferative. Just to go into the different pathology, just to break down the palm coin, I'm sure the residents are all familiar with this. This came out, I don't know, about 10 years ago in terms of looking at the structural versus non-structural causes of post or abnormal uterine bleeding. With the hysteroscopy, you're really going to be able to focus on the polyps, the fibroids, and malignancy or hyperplasia. So obviously this is a hysteroscopic view of a polyp. It's clearly visible and you're able to see. If you don't do the procedure on day 5 to 9 or do the progesterone withdrawal, sometimes it's difficult to actually see individual polyps, and you may miss these and confuse them with secretory or proliferative endometrium. Just briefly to go over the polyps, because you're doing the hysteroscope on patients, so it's important to be able to counsel your patients on polyps. Usually they're found increased risk factors are age, hypertension, obesity, basically that anything that increases estrone or estrogen to the lining of the uterus. So with obesity, we all know from aromatization that certain steroids are converted into estrone. Also tamoxifen use, patients with breast cancer that are on tamoxifen, premenopausal patients, because mostly postmenopausals will be on an aromatase inhibitor, but those with tamoxifen also increases the risk of polyps. Abnormal uterine bleeding, patients with polyps, about 60 to 70% will present with abnormal bleeding. The typical symptoms for polyps are bleeding after intercourse, or bleeding or spotting between cycles. Endometrial polyps cause bleeding by they get congestion at the end of the polyp, and it causes to stasis, which leads to necrosis, which leads to bleeding of the blood vessels. Polyps can also be associated with infertility. And polyps and atrophy are the most common causes of postmenopausal bleeding. One of the most common causes is polyps. So arguing in favor of hysteroscopy. So I hope that people have gone away from just doing blind D&Cs when they're dealing with abnormal uterine bleeding. Blind D&Cs only remove 8% of polyps. Adding polyp forceps removes 41%. But when you're adding hysteroscopy, that number goes closer to 100%. It's important to let your patients know about recurrence after removal of polyps. There's about a 2.5 to 3.7% of polyps recurring. So it's important to counsel your patient on that, especially if they have the above mentioned risk factors of obesity, tamoxifen use, hypertension. You don't want to do the procedure, have them come back a year later and find out they have another polyp, and why didn't you remove the polyp? Well, I did, but they can recur. Also, visualization and direct removal with the hysteroscopy has been shown to have decreased recurrence, because you're probably getting the polyp more at the base and removing it in its entirety. Talking about fibroids, so submucosal fibroids obviously lend themselves to being resected hysteroscopically. Just to go over the different types of submucosal fibroids, there's a classification system: type 0, type 1, type 2. For the residence purposes, to remember type 0, it's 100% in the cavity. There's a 0 in type 0 and a 0 in 100%. For type 1, that's when greater than 50% is in the cavity. Type 2 is when less than 50% in the cavity. And it's important to know this going into the case. Then you're able to really counsel your patient on your ability to successfully resect the fibroid, depending upon if it's type 0, 1, or 2. Different ways to figure that out prior to taking the patient to the operating room would either do a saline infusion sonohystogram or an MRI. I often will get MRIs on patients or saline infusion sonohystogram, and it's important to get in the habit of looking at the images yourself rather than just reading reports. I try to look at all my images of all my patients for all my procedures because I find it extremely helpful. So type 0s, these are the most successfully able to be resected, and the type 1s also. In terms of the mechanical morcellators, these are the ones that you really are able to get with that. The type 2s, you really can't. I equate it to using chopsticks versus a 3D. So the morcellators, the mechanical morcellators like the TrueClear, it's kind of, if you think about like laparoscopy, you're limited in the dimensions in which you can resect the fibroid, whereas with the resectoscope, it's more of a scoop shape, so you're able to really dig into the fibroid and get more of it out, in my opinion. And that's been my findings. So, oftentimes being able to offer patients hysteroscopic fibroid resection is a very minimally invasive procedure. Recovery is rapid. The patients go home the same day. I do a lot of these with patients with infertility or abnormal uterine bleeding. It's very important to develop the skill set so you can really serve your patients well. Moving along to malignancy. So that's the other thing. When you do a hysteroscopy, you're able to visualize the lining of the uterus. Just to briefly go over endometrial cancer. Obviously, it's prevalent. It's one of the most common types of gynecological cancer. Old classification, I know we talk about simple hyperplasia, complex, simple with and atypical, and complex atypical. Now it's just endometrial neoplasias. The coins are there just for the residents. So about 1% of simple hyperplasia will progress to cancer. 5% of complex hyperplasia will progress to cancer. About 10% of simple atypical hyperplasia will progress to cancer. This is if nothing's done. And 25 to 40% of complex atypical hyperplasia will progress to cancer. So this is just a good way to remember 1, 5, 10, 25. It gives you a rough outline. Endometrial cancers, we know, are divided into type 1 and type 2. Type 1 is obviously the endometrioid, the most common. This is the one that you'll find in your obese or PCOS patients, the patients with unopposed estrogen, the large BMI, tamoxifen use. You usually have a thickened lining with these patients. The type 2 are more aggressive, clear cell, uterine serous. These are estrogen independent, meaning you could be a thin patient, doesn't have the risk factors. You'll find them in older women, multiparous smokers. The lining is not always thickened with these patients. Hence the reason why if you do an endometrial biopsy and the patient continues to have postmenopausal bleeding, you have to evaluate that further and you're getting an ultrasound, because even if the lining in a postmenopausal woman is less than 4 millimeters, but they have persistent bleeding, you need to sample the lining, because with the type 2s, you can have lining less than 4 millimeters. Also on polyps, you can develop cancer. I've found a few of those where the cancer was limited to the polyp. Those usually would be the uterine papillary serous carcinoma. So in terms of being able to identify malignancy and pre-malignant lesions, there has been several studies that have been performed and different systems that have come up with to help be able to differentiate or determine the probabilities of finding cancer. So I did my fellowship through the AAGL. Dr. Frank Leffler is one of the founders of the AAGL. And in 1989, he came up with something called a negative hysteroscopic view. What is that? Basically, like the picture I showed you in the beginning of the slides, down where you can see in the bottom right, where you have a normal appearing atrophic endometrium. If you have good visualization of the entire cavity, there's no structural abnormalities, and it's uniformly thin or homogeneous appearing, you could be almost certain, not 100%, but almost, that there is no precancerous or cancerous lesion, and that has been called the negative hysteroscopic view. So a very good negative predictive value if you go in and you see nothing. So office endometrial biopsies only sample about 4% of the lining of the uterus. When you do an office endometrial biopsy, only 4% of the lining is sampled, which is not a lot. The reason we do it is the thought is if there's cancer there, then it would be everywhere and you'd get it, but it's only sampling 4% of the lining. However, I like to, and the talk of this lecture is that hysteroscopy is basically the stethoscope for the gynecologist, and it's the gold standard. So by looking inside, you can see lesions that you may otherwise miss, and I've had that several times. Endometrial biopsy in the office was atrophic endometrium, do a hysteroscopy, and it comes back that there's cancer or complex hyperplasia with atypia. So to do a hysteroscopic directed biopsy, you can see on the bottom left, I have a 4.9 millimeter slender scope here. If you're using the TrueClear, you could also do that, but I think the ability for the tissue to be trapped into that bag that catches it and then sent to pathology is probably unlikely it's going to survive. So with this, you basically put the hysteroscope in, use these graspers, any abnormal appearing tissues you grasp, and you can, when you take out the graspers, rather than pulling it through the operative channel, remove the hysteroscope and the graspers as a unit so that the tissue doesn't get lost. And sometimes you even have to use a blunt needle tip because the tissue is obviously very small. So you may have to take several samples to hand off on a piece of, to hand off for pathology. So this is what we're going to go over, some things that can appear, abnormalities. So hyperplasia, this is what the appearance of hyperplasia could look like. Again, it's difficult to differentiate just from looking at this based upon, differentiating this from secretory or proliferative endometrium, but this is what hyperplasia looks like. Simple hyperplasia has appearance similar to this. Atypical endometrial hyperplasia, it's important to know that there's a concurrent prevalence of endometrial cancer in patients with endometrial hyperplasia with atypia. It's quoted about 30 to 40% of the time. It's more difficult to identify the atypical endometrial hyperplasia than endometrial cancer, but that's not super important to differentiate that just by looking, because you're going to take a sample of it and send it off to the lab, and that's where it can be better identified. This is appearance of what complex hyperplasia with atypia looks. This compared to this, you could see this is more angry appearing. You could see vessels. So if you just think about it compared to colposcopy, when you do a colposcopy, it's the similar things that you're looking for, atypical vessels. And there's been studies done over the past 10 years about possible hysteroscopic variables for classifying, to be able to detect what it's, is it going to be cancer or not? The studies have looked at different lesion morphology, such as circumscribed, polypoid, nodular, papillary, ulcerated lesions, the endometrial surface, the thickness, the vascularization, the color of the lesions. If they're whitish or grayish, they're more likely to be cancer. In terms of involvement of the endometrial cavity, which is something that you can gain by hysteroscopy, not by blind biopsies or office endometrial biopsies, they found that if less than 50% of the lining is involved, 97% of the time at stage 1, if it's more than 50% is involved, your chance of finding greater than stage 1 is about 30%. This was just to look at some studies specifically. These were some proposed scoring systems, similar to how we have scoring systems to determine whether or not a ovarian cyst is concerning for cancer or precancer. always trying to come up with scoring systems to determine what type of lesions, what their appearance would be if they're cancerous. This study also confirmed Dr. Loeffler's study about the negative view at hysteroscopy. They found the negative predictive value of 99.5% when you meet the criteria that I explained above, having a thin, homogeneous appearing uterus, being able to visualize the entire cavity and not having any lesions. You can see that the sensitivity for finding endometrial adenocarcinoma by using these criteria was 95% sensitive and 98% specific. Again, these are some of the criteria that they use in their scoring system. These are an example of papillary projections that would be associated with or concerning for cancer. Vessels, atypical appearing vessels. You can see the different vessels. Again, just think about it like colposcopy in your mind when you're doing a colposcope. It's a similar type of findings you're going to find in the endometrial cavity. Also, you can visualize seeing spread to the cervix of endometrial cancer. There were studies that showed that by seeing it in the cervical canal, you're able to differentiate whether or not it has spread. Just another picture of the atypical vessels and endometrial cancer. And then there's been studies or concern about potential intraperitoneal dissemination. Basically, there's been multiple studies. They found that there is increased risk of finding cancer cells on cytology. However, they found that it does not clinically affect the patient, and they do recommend hysteroscopies. Same with type 2. So some takeaways: hysteroscopies are very helpful. Take hysteroscopically directed biopsies. You don't necessarily have to differentiate by looking whether it's cancer or not, but it's good to know what's abnormal so you could sample it. And hysteroscopies, I think we're running out of time, so I'm not really going to go into congenital uterine abnormalities, but hysteroscopy is very helpful for treating those as well, whether they're septums or Asherman syndrome, and removing things such as retained IUDs or even retained products of conception. I've done several of these using the bipolar resectoscope. Oftentimes they're calcified. You cannot do these with the MyoSure. So being able to have the skill set to remove these is pretty awesome. And that's my presentation. I hope you guys enjoyed and learned.
Dr. Lieberman, thank you so much. Thank you for that excellent review. Are there any questions? Here at Robert Wood, we have the TrueClear device. And I think that the TrueClear is just amazing for polyps. It just sucks them right up and they're gone. I love that. But I don't have that kind of luck with fibroids. I don't have a problem with the angle that you were referring to. What I have a problem with is they just won't chew through a tough fibroid. Do you have any advice for that?
Yeah, use the bipolar resectoscope. I guess you could use maybe the MyoSure. I know it has a bigger jaw, but that's a common thing that I hear about being unable to quote unquote chew through the fibroid, or if the fibroid is calcified. I've had a lot of patients refer to me after they've been taken for a hysteroscopic fibroid resection. I'm able to do it using the bipolar resectoscope. So I don't really know, what could be done using the mechanical morcellators to improve the efficiency of that, though.
I see that Dr. Phillips has her hand up.
Hi, thanks for that great presentation. I have a very basic question. Do all polyps need to be removed?
No. So all polyps don't need to be removed. So basically, depending upon the age of the patient, the size of the polyps, if a patient's in her reproductive years, she doesn't really have risk factors, it's less than 1 centimeter, about 25% of those regress on their own, and you can counsel the patient on that. Patients with risk factors greater than 1.5 centimeters of the polyp, postmenopausal patients, patients on tamoxifen, those need to be removed. 1 to 12% of polyps can contain cancer. So those should be removed.
And postmenopausal patients, regardless of the size of the polyp?
I remove them, yeah. I recommend removing those, especially if they're symptomatic. If they're having postmenopausal bleeding and they have a polyp, yes, it should come out.
Well, if they're it's the asymptomatic ones are the more difficult ones because you're doing an ultrasound for some other reason.
So
and
if
you
you do
find
ultra,
like a 4 millimeter polyp in somebody who
rec-
has no bleeding.
and if they have risk factors, I would remove it. I would counsel the patient and recommend removing it. And then it goes back to, the same with the thickness of the lining. If you have a postmenopausal woman who's found to have an endometrial lining of less than 11 millimeters and they have no bleeding and there's no increased vascularity or fluid in the cavity, you don't have to sample it. So, you know, I would recommend removing those, and especially if they have risk factors, if they're obese, if they have hypertension, diabetes, yeah, I would take those out.
Thank you.
Any other question?
It doesn't look like there are. So, and we're just about out of time. So Dr. Lieberman, thank you so much for this excellent talk.
Well, thank you for the opportunity. I apologize for the interruptions. It's frustrating. And thanks for taking me out for dinner last night. And it was really great. So I appreciate the giving the talk to you guys. And I hope you learned something.
Absolutely. Thank you so much. So we'll end it here. I wish everyone a safe and productive day. Thank you.